Okay, let's go. This is test day panic. Time is short, the stakes are high. We're hitting the absolute must-know pharmacology notes, mechanisms, contraindications, patient teaching, everything you absolutely need for the exam right now.
Totally. Fast, focus, we're covering every critical detail, safety check, black box warning from your material, no fluff.
All right, section 1, cardiovascular. Let's start with blocks and clots, calcium channel blockers, diltiazem, amlodipine. What's the core goal here?
We're trying to decrease the oxygen demand of the heart muscle itself, the myocardial cells, so really beneficial for things like CAD and angina.
Got it. And the major risks, the things you have to watch for.
Okay, two big ones specific to these drugs. They can cause heart block. And surprisingly, gingival hyperplasia, that's the overgrowth of gum tissue.
Oh, okay. And the food interaction.
Yeah, yes. Always teach patients to avoid grapefruit juice. Big one. And of course, standard monitoring for hypotension, watch for falls.
We hear that grapefruit warning a lot. Why is it so critical, especially here?
It really is crucial. Grapefruit inhibits certain enzymes like CYP450, which are needed to break down to metabolize many drugs. If that metabolism slows down, the drug level, the CCB level here, shoots way up.
Leading to?
Severe hypotension, maybe even serious cardiac events. It's a major interaction.
Okay, super important context. Let's pivot to beta blockers.
Yeah.
Metoprolol, atenolol. What's the absolute first thing you do before giving a dose?
Check the heart rate, period. It must be over 60 beats per minute, no exceptions.
And for patients taking it long term?
You have to drill this into them. Never stop taking it abruptly. Seriously, sudden stopping can cause dangerous rebound hypertension or really bad angina.
This is the hidden danger with beta blockers, especially if the patient has other conditions.
Right. They're kind of notorious for masking the signs and symptoms of hypoglycemia, meaning a diabetic patient might not get those usual warning signs like a racing heart or tremors when their blood sugar drops dangerously low. The beta blocker hides it. Very risky.
And the absolute contraindication regarding the lungs.
Do not give beta blockers to patients with asthma or COPD. They can block beta-2 receptors in the lungs. That stops the natural bronchodilation we need, potentially triggering airway constriction, a respiratory crisis.
Okay, so heart rate managed, BP managed.
Yeah.
Now, acute clots, thrombolytics, the big gun, alteplase or TPA. What's its specific job?
Its job is dissolving acute thrombus disorders. Think pulmonary embolism, acute ischemic stroke. But yeah, it's potent, high risk for bleeding if not used right.
So let's lock down those absolute contraindications. When can you absolutely not use it?
Okay, number 1, any sign of an active bleed, especially any intracranial bleeds within the last 3 months, that's a definite no. And number 2, uncontrollable hypertension. The system's got to be stable.
Administration safety points.
It needs its own dedicated IV access. You absolutely cannot mix it with any other IV drugs.
And once it's infusing.
You watch like a hawk for bleeding. Specifically, look for a sudden headache or any new confusion. Those could signal a really bad internal bleed, life-threatening.
All right, section 2, blood and clotting regulators. Moving from clot busters to clot preventers. Anticoagulants. Let's do a quick compare-contrast for warfarin and heparin.
Good plan. So for warfarin, you're monitoring PTINR.
PTINR. Got it.
Antidote.
Okay.
Okay. And heparin.
For heparin, monitor PTT,
PTT antidote.
protamine sulfate.
Perfect. We often hear about bridge therapy. Why is that necessary when starting warfarin?
Yeah, because warfarin takes a few days, sometimes longer, to actually start working effectively to reach that therapeutic level. So we use heparin, often the low molecular weight kind like enoxaparin, which acts fast, to provide that anticoagulation until the warfarin is fully active. We bridge the gap.
Makes sense. What are the universal warnings for pretty much all anticoagulants?
First, tell patients to avoid NSAIDs, things like aspirin. Greatly increases the bleeding risk when combined.
Okay.
And remember, there's a universal black box risk for bleeding. Specifically for enoxaparin, call out that risk of epidural bleeds.
And their general use. Mostly used to prevent clots, think conditions like AFib, CAD. Also used sometimes to stabilize ischemic strokes if TPA can't be used.
Okay, let's switch gears to a really specialized one. Hydroxyurea, used for sickle cell, some blood cancers. Mechanism?
It inhibits blood cell production.
Okay, that sounds like it creates some unique safety issues.
It does. For the nurse administering it, hydroxyurea is an exposure toxin risk. You must wear gloves, handle it carefully, dispose of it properly.
And for the patient taking it?
They should not chew the medication. Swallow it whole.
Since it inhibits blood cell production, what are the 2 main risks for the patient?
High risk for infection because white blood cells are down, and just generally low white blood cell counts, leukopenia.
Hmm.
There's also a black box warning about immune system suppression. It can even cause secondary cancers like leukemia or skin cancer down the line.
Wow. So patient teaching must include.
Absolutely must wear sunscreen when outdoors. Crucial teaching point.
Right. Okay, wrapping up blood modulators. Antiplatelets. Clopidogrel, aspirin. These work differently, right? Preventing aggregation.
Exactly. They stop platelets from clumping together. So, used a lot in CAD to reduce stroke or heart attack risk.
There's a specific instruction for aspirin in one situation.
Yes. For CAD patients having unstable angina, the instruction is often to chew the medication. Gets it absorbed faster in that acute situation.
Interesting. And clopidogrel has its own specific black box warning. Something about metabolism.
That's right. Some people have genetic variations that make them metabolize clopidogrel really slowly, which means the drug doesn't work as well for them. They don't get the expected antiplatelet effect, leaving them at risk.
Important to know. So, general teaching for someone starting antiplatelets.
They need to tell their dentist, tell their doctor they're on it before any procedures. Bleeding risk.
And food interactions. Besides the grapefruit again.
Yep, avoid grapefruit. Also, garlic can increase bleeding risk, and foods high in vitamin K can sometimes interfere, though that's more of a warfarin issue. It's good to be aware.
Okay, Section 3. Specialized cardiovascular and renal agents. Kicking off with antiarrhythmatics. Amiodarone, lidocaine. Very specific use case here.
Highly specific. They are used to treat ventricular arrhythmias, things like VTach, VFib. They work by prolonging the action potential in the heart cells, often reserved for serious rhythm problems.
Let's talk about amiodarone's toxicity. Sounds like a big deal.
It is a big deal. That's why it's often saved for life-threatening situations. It has a major black box warning for both lung and liver toxicity.
Lung and liver.
Yes. And it has a narrow therapeutic range, meaning the difference between an effective dose and a toxic dose is small. So frequent lab monitoring is essential.
Okay, what about lidocaine? We know it can cause CNS depression. What's the critical drug interaction to avoid?
You cannot give lidocaine along with beta blockers.
Fine.
Both drugs slow down the heart and decrease how strongly it contracts. Giving them together can have an additive effect, leading to severe bradycardia, even potentially a systole. Very dangerous combo.
Got it. Next up, sacubitril valsartan. You mentioned this has a very restrictive indication.
Extremely restrictive. It's used only for patients who have left-side heart failure with a reduced ejection fraction. It's not for all types of heart failure.
Understood. What are the key safety points and teaching needs right off the bat?
Huge teratogenic risk. Absolutely do not give during pregnancy or breastfeeding unless maybe the mother's life is directly at stake.
Okay.
Patients also must report any signs of angioedema, swelling of the face, lips, tongue. And critically, remember that African American patients have a statistically higher risk for this specific side effect.
That's vital. And because it often causes dizziness, lightheadedness, hypotension, the nursing intervention is.
Fall precautions. Definitely implement fall precautions.
Mm-hmm.
We also need to keep a close eye on their potassium levels and kidney function, renal function, because electrolyte imbalances are a known risk.
All right, let's move to nitrates, the classic for angina. If using patches or ointments, run us through the rules.
Okay, for patches, always take the old one off before putting a new one on. Apply it to a clean, hairless spot. Rotate sites. And yes, they can usually wear the patch in the shower.
And the ointment.
For the ointment, the nurse absolutely must wear gloves when applying it. And do not rub it in, just spread it lightly over the prescribed area.
What about the sublingual tablets or spray?
Sublingual doses should not be swallowed. Let them dissolve completely under the tongue. Store them properly to cool, dry place in the original dark bottle to keep them potent.
Nitrates cause significant vasodilation. This leads to some expected, though maybe unpleasant, side effects. Let's list those clearly.
Right. Because of that vasodilation, patients often experience hypotension, low blood pressure.
Okay.
They also commonly get a pretty significant headache and flushing, like redness or warmth in the face and neck. We need to teach patients these are likely to happen.
Now, arguably the single most critical contraindication for nitrates, the absolute no-go.
They absolutely cannot be taken with phosphodiesterase inhibitors. Think drugs like Viagra, sildenafil, Cialis, Levitra.
Why is that combination so deadly?
It causes massive, excessive vasodilation. The blood pressure can drop precipitously, leading to profound, potentially fatal hypotension. It's an absolute contraindication. Also, Don't give if the patient already has increased intracranial pressure.
Okay, switching to statins, atorvastatin as our example, used for cholesterol, reducing coronary artery buildup. Let's go straight to the most serious, though rare, risk.
That would be rhabdomyolysis. Rhabdo.
Explain that.
It's severe necrosis, basically death, of muscle tissue. And that includes skeletal muscle and potentially heart muscle. It's a medical emergency.
How do we monitor for it? What does the patient need to report immediately?
We monitor labs, specifically creatine kinase or CK levels. High CK indicates muscle breakdown. The patient must be taught to report any unexplained muscle weakness, tenderness, or pain right away. Don't ignore it.
What about liver and metabolic effects?
We need to monitor liver function tests, LFTs, because statins can sometimes cause liver problems, either temporary or permanent. They can also contribute to hyperglycemia, so watch blood sugar.
Any other risks or key interactions?
Well, they can sometimes impair memory, cause confusion. Atrial fibrillation has been reported. Definitely teratogenic, so no pregnancy or breastfeeding.
And that familiar warning.
Avoid grapefruit juice. Yes, again. Statins can also increase digoxin levels, so watch for potential digoxin toxicity if a patient is on both.
Right. And when's the best time typically to take a statin?
Usually recommended at night.
Yeah.
And always emphasize that it needs to be combined with lifestyle changes like a low-fat diet. It's not just about the pill.
Last class.
Yeah.
ACE inhibitors.
Mm-hmm.
Lisinopril, captopril. Used for heart failure, hypertension. What are the two classic, very common side effects?
Orthostatic hypotension, dizziness when standing up, and that notorious persistent dry cough. Many patients get that.
But the most dangerous potential side effect involves the airway.
That's the risk for angioedema. Swelling of the face, lips, tongue, throat. It can obstruct the airway.
So the patient teaching is?
They must know to tell their provider immediately if they notice any swelling of their face or mouth. It's an emergency.
ACE inhibitors also carry a significant electrolyte risk. Which one?
They are well known to cause hyperkalemia, high potassium levels.
Okay, so based on that hyperkalemia risk, what's the critical teaching for the patient?
They need to avoid foods that are super high in potassium. Also avoid salt substitutes, as those often contain potassium chloride. And no extra potassium pills unless specifically ordered and monitored.
And other safety points.
Monitor renal function closely. And just like beta blockers, never stop taking the medication suddenly. You have to taper off slowly to prevent rebound hypertension.
And finally, the pregnancy status.
Another teratogenic one. Should not be taken during pregnancy.
Wow. Okay, that was a whirlwind, but incredibly dense. We had antidotes, protamine sulfate, vitamin K, strict admin rules for TPA, nitrates, multiple critical black box warnings, teratogenicity across several classes. What's the single biggest takeaway concept from all this?
I think it's recognizing the hard boundaries, the absolute non-negotiables. Knowing you cannot stop ACEs or beta blockers abruptly, knowing the specific dangers of imidazole toxicity, and especially those potentially fatal drug combinations, nitrates and Viagra being the prime example, nailing those high-risk interactions is paramount for safety.
Absolutely. Those hard boundaries save lives. Okay, final provocative thought for you heading into the exam. We hit the avoid grapefruit juice warning for CCBs, statins, and antiplatelets. Why? What is the single most important mechanism the nurse needs to explain to the patient about avoiding that specific fruit? Think about the underlying reason.
Right. It comes back to that CYP450 enzyme inhibition. Understanding how that impacts drug metabolism and concentration is key.
Exactly. Master that concept. Okay, that wraps up this test day panic session. You have the critical facts. Focus on those hard boundaries, stay sharp, and go ace that exam.